Good evening, everyone, and thank you, AIOS Scientific Committee, for giving me this opportunity. The topic is Phaco emulsification, easy for beginners. In this topic, I will be explaining about the hemisphere chop, which I do normally, which involves very less power. Nucleotomy is the crux of any phaco emulsification surgery, as that is what separates it from MSICS. For any beginner, while advancing to phaco emulsification from ECC or MSICS, the biggest challenge is to use the phaco machine, that is, in the phaco power, which is used to do nucleotomy. Rest of the steps like Rexis and IOL delivery are mostly similar. Now, what are the complications that may happen during nucleotomy? They are PC rent, corneal endothelium damage, and Rexis margin tear due to capsular margin getting caught in the chopper. In the following slides, I will try to demonstrate my technique of nucleotomy, which help reduce these complications during the learning phase of my phaco emulsification surgery. Now, making the groove. After finishing the Rexis and hydrodissection part, the first step, which I do, is making a central deep groove in the nucleus. For this, the settings which I normally use are aspiration of 20, vacuum of 100, and power of 60 to 100, depends on the hardness of the nucleus. Now, we should remember that the depth of the groove should be about 80 to 90% of the depth of the nucleus, which for an easy way, we can see that it's about 1 to 1.5 times the size of the tip. And it can also be determined, if you have a good microscope, by the red glow of the retina, which can be seen at the depth of the tip. The second part of an important tip here is that the groove should be boat-shaped. That is, in the periphery, it should be shallower. In the center, it should be deeper, as that is how the nucleus is. Second part, hemisphere separation. Here, the two halves of the nucleus are separated. Now, there are two methods. One is the manual method, wherein after filling the AC with viscoelastics, we can use two Sinskey hooks, a chopper or a Sinskey hook, to separate it manually. Herein, we have to insert the two Sinskey hooks through the two side ports and keep their ends at as deep possible in the groove as much and pull them apart, thus separating the two hemispheres. Now, the second method for slightly more advanced surgeons who have better pedal control is using one phaco tip and one chopper. That is, using the phaco tip with only aspiration mode on, we can separate the two pieces. The advantage of this technique of nuclear breaking are less chances of corneal endothelium damage, as less phaco power is being used, and also nuclear pieces are not flying around. Low vacuum settings are used here when using phaco tip. Hence, chances of surge are lesser, which is very suitable for low-end machines also. Manual separation also reduces risk of inadvertent PCR occurring due to any uncontrolled phaco power being delivered while doing direct chop or stop and chop. Most of the instrument manipulation is done at the central area at a deep level, which is deepest. Hence, chances of instrument touch to cornea is also less. Now, next step is emulsifying and aspirating the two hemispheres which we have created. Now, after separating the nucleus into two pieces, one by one, each piece is emulsified and aspirated. During this junction, the settings which I normally use are 300 to 350 vacuum, 60 to 80 of power depending on the hardness of the nucleus, and 34 to 38 of aspiration. These settings are variable depending on the type of machine. Like in a low-end machine, I will keep my aspiration and vacuum settings at a lower end, while on a high-end machine, we can keep them higher due to chances of surge are lesser in them. At the end of this process, a rim of cortex remains, which is cleared using irrigation aspiration, and IOL is placed in the bag. Thus, the take-home method is no power chop is a very easy method of nuclear separation in phaco emulsification, which is reproducible by most phaco surgeons, even beginners. In this technique, the chances of PCR and corneal damage during chopping are greatly reduced. And if by some chance PCR does occur, then because there is not much inflow or outflow from the AC, and AC is filled with viscoelastics, vitreous prolapse is minimal, and also chances of nuclear pieces falling into the vitreous are lesser. And this case can be easily converted to MSICS or ECC and managed.